TopMedTalk.
Well, hello and welcome to TopMedTalk. We're in Denver, Colorado for the Society for Obstetric Anesthesia and Perinatology, or SOAP. I'm Desiree, Chappell, co-editor-in-chief of TopMedTalk and your host today. And joining me as my co-host, the former editor-in-chief, Monty Mythen. Hello, Monty.
Thank you for having me back, Desiree.
Yeah,
what's it did this meeting? Wonderful meeting.
It is a wonderful meeting. Thank you for filling in for Mike Grocott, who is now our co-editor-in-chief of TopMedTalk, who couldn't make it, but good to have you here. You have formally left us, Monty.
So last August, and I keep repeating this, but, conflicts of interest. I joined Edwards Life Sciences. I retired from the university, although I'm still an emeritus professor at UCL. I retired from the National Health Service. I joined Edwards Life Sciences, who were the original founding sponsors of TopMedTalk, unrestricted grants. So we all agreed together that I should step down as the editor-in-chief, but I'd be allowed to sit in for podcasts when it was deemed to be appropriate. So thank you, Leslie. We sit in today.
Absolutely. We've had a lot of fun. And thank you to all of our sponsors for the support that they give us for keeping TopMedTalk free and open access to the world. And thank you to SOAP this year for having us at their lovely meeting. They've given us a booth here in the exhibit hall, and we have had some phenomenal conversations. A lot of new content that we haven't necessarily talked about on TopMedTalk. So if you haven't had a chance yet to listen, just check out the SOAP combos. They've been
really, really excellent conversations.
Yeah, great. Part of what we do, as everyone knows, as a listener of TopMedTalk, is sit down in the exhibit hall with attendees, presenters, people from the board of directors for the meetings that we're at, and also presidents, past presidents of the organization. So today we are so lucky to be sitting down with a past president of SOAP, Dr. Ruthi Landau, who is the Virginia Apgar Professor of Anesthesiology at Columbia University in New York. Ruthi, if I may, thank you so much for sitting down with us.
Good morning. I'm delighted to be here. It's always exciting to be recording important content, and I feel very privileged to be here with you.
Yeah.
And that is a great title to have. So we have a very broad listening audience, which includes many clinicians, but also many non-clinicians. So not everyone's going to know who Virginia Apgar was and how important she is to our specialty. Could you give us a quick update?
Of course.
Quick reminder.
Reminder.
People who have children or have had children know that when their baby is born, there's going to be a score that is going to be given to the baby, the Apgar score that goes from 1 to 10. And without going into the details of the scoring, but it is a good predictor of neonatal well-being. And it was developed and later validated, but Virginia Apgar, who everybody thinks is a pediatrician, was actually an obstetric anesthesiologist. And she was impressed at how babies were born and left unattended, and she thought that it would be good if someone from the healthcare team would observe the babies and attend to them. So she developed the score in the 50s. And there are millions and millions of babies now who each have an Apgar score that have assessed how they did at birth. So there's an endowed professorship at Columbia University to honor her work because she was the division chief of obstetric anesthesia. And there have been so far 2 Virginia Apgar professors, my predecessor, Richard Smiley, who's here in the meeting, and myself.
Wow, what a great title. Congratulations.
Thank you.
Yeah, that's fantastic. Well, we were having a little conversation about SOAP, and we've been talking to different folks throughout the organization to talk to us and tell us more about the organization. We want to learn more. We have learned that it's been around for about 55 years, correct?
So SOAP started off as an opportunity for anesthesiologists interested in obstetric anesthesia research to meet, and we hear that they were meeting at each other's house and inviting each other and brainstorming research ideas. And then it became, a more formal society with an actual program and a meeting. And it has tremendously evolved. And it's not that much of a young society anymore compared to other societies. But the goal of SOAP, and we have a very clear mission and vision and value statement, which I will not describe because it's accessible, but the goal is to really gather people who, care for pregnant women and improve maternal health and outcomes through clinical guidance. So SOAP develops consensus statements. SOAP develops content through the education committee. And we also have a very vast research network, and I just came out of the Research Network Symposium where people present their projects to get feedback and improve the study design, the methodology, gather more centers. So a lot of the projects now are multi-center multi-center research projects, which increases the validity and the ability to answer difficult questions. And we also have registries. So there's a very robust now mechanism to have different academic centers and non-academic centers present projects that can enroll sites. So one of the first projects that has been started and launched is the SOAP General Anesthesia Registry, trying to address outcomes for events that are relatively rare. And having the ability to do it through the research network is very important. And last but not least, which we mentioned earlier, is that there is over 500 research and case reports abstracts that are presented, which is wonderful. And it's not just from the United States, it's international. We have people from around the world, and it is always fantastic to see what other institutions are doing and presenting. So a lot of content at SOAP.
Yes, it's great.
Could I ask you to expand a little bit on the registry? Because there's a lot more interest globally in the potential to use registries to do research more rapidly. So is it a voluntary registry? Is it web-based portal? All those sorts of things. How do you get the information? How's it shared?
So it depends on the project. Specifically for the General Anesthesia Registry, because we want to collect very specific information, it is a retrospective and prospective. In other words, the ability to collect data that would go beyond what is accessible through healthcare records is important. And so centers have shown interest, have been vetted in their ability to actually complete case report forms in a reliable manner. There's also a lot of logistics that go for data sharing. So there's a PI, and the centers who contribute data have to have IRB approval from their own institutions and data sharing mechanisms, which is why it is complex on the one hand, but very robust on the other, so that the data is reliable, validated, and the data has been vetted through the SOAP Research Network with a really iterative process to be sure that we get the amount of data that is important without being too cumbersome. So a lot of elements that we thought we might want to collect were actually removed from the data collection because it would preclude certain centers from being able to, gather the data. So it took 2 to 3 years to actually pull this off the ground. And the PI, I will congratulate her, Dr. Lisa Leffert, who is also a SOAP past president and is located at Yale and is putting a lot of thought and her heart and her soul into that registry.
You're also working on the Committee for the Center of Excellence, correct? Tell us a little bit more about that.
So the Centers of Excellence started off in 2018 with a goal to establish a blueprint for excellence. So it's not the minimum standard of care. There are other societies that have established that to try and bring, centers of countries to what would be considered the standard. This is excellence. SOAP thrives to promote excellence, and this was a way to establish benchmarks. So it started off with a process where institutions applied, and obviously it was considered initially as the ivory tower, the academic centers, Stanford, Hopkins, Brigham, Columbia, all self-congratulate, tap on their shoulders. So we have absolutely not had that in mind, and the process has evolved in a way that I feel very proud of, and I will share with you what it is. First of all, it serves as a tool, as an instrument, because having all the elements that have been described, and they're all based on evidence. So there's a task force that sat around the table. We almost, had a Delphi process to establish what seems important. We have essential criteria. We have non-essential criteria. And this allows centers who might know that they don't qualify for the designation, but that allows them to work towards achieving the designation. So if it is staffing, if it is supply, if it is coverage models, it allows them to go to their hospital administration, to the chair of a department and say, this is what we're missing to achieve excellence. So now it's a decision of the hospital administrators or the chair of the department. Do you want us to be a center of excellence or not? And if we don't meet the criteria, this is what we need.
I just unpick that a little bit. Sorry to interrupt you. So just I've got a worked example so I understand. I've got an OB unit somewhere and I'm scoring, let's call it an 8 out of 10. So what I'm missing is, for example, certain staffing ratios, or I'm missing a difficult airway cart with all the bells and whistles on it. You've empowered me indirectly or directly to go to my people who hold the purse strings and say, we're only too short of being excellent here. Have I repackaged that correctly?
Exactly. You have absolutely repackaged it and reformulated it in a great way.
We've got an 8 out of 10.
Yeah.
And all you need to do is give me the staff I asked for and give me the cart I asked for, and we'll be excellent.
Exactly. So we do it in several steps. So there is, first of all, the application form is accessible so people can see ahead of time. Then there is an intention to apply, and then there's a few months for the centers to prepare their application. We offer a consulting services. In other words, if someone thinks, I'm really so far from it, should I even consider applying? It's a bit like, submitting your paper to a journal, and you get your reviewers who tell you, oh, this is a flat reject, like that's reject, this is too bad, it's unsalvageable, fatal flaws. Or, you know what, how about you address this, you address that, and come back. And actually, through the review process, the review committee works really hard. We're 18 or 20 members in the review committee, and we really discuss the applications, and we say, first of all, we review based on whether essential criteria are missed. So when the essential criteria are missed, it's sort of fatal flaw. Yeah. This is really not a center of excellence. But if it's a number of non-essential criteria that are missed, we tell them, listen, we think you can do that. Like you're missing a difficult airway cart on your floor, or there is no hyperthermia managing strategy for malignant hyperthermia strategy management on your, this is something you should be able to achieve. And they tell us, we'll get it. Thank you. We're going to get it. So they get the designation. So it is a 6 to 9 month process. And we sort of give a waiver to reapply for those whom we think you just need one more year to get it, and you'll get it next year. And then the 2 new features that we've added on this year that I want to describe because I think it's important. We appreciate that not all centers that provide excellent care are tertiary academic referral centers. And we want the smaller, so low volume, low acuity community practice who provide excellent care for their type of institution to be able to receive the designation. So we have now a 2-tier designation. So we have the academic referral tertiary center designation and the regular one, which we don't call regular. So the centers of excellence without the accolade of being a tertiary referral center. And they're accountable for different criteria. So we have a 2-tier, and we want to encourage the community, low-volume, non-academic centers to receive the designation and feel comfortable in submitting their application, knowing that they will be scored or reviewed in a different manner. So that's the first element that I want to emphasize here.
Can you give me a sense of numbers here? So that
that's
I'm guessing the sort of big ivory towers are doing 10,000 deliveries a year, plus or minus a few thousand. You get down to the mid-sized ones are doing thousands of deliveries. Now, the very small places you're referring to, are they down into hundreds of deliveries per year?
So there is an excellent center that received the designation that performs 500 deliveries, but they had excellent care, good coverage for that size. They followed all the SOAP consensus statements, recommendations. It was flawless. They received the designation. So we want to encourage centers. We think it's important, the centers receive a plaque. Yeah. They can have media to really, be rewarded for their excellent care, and to encourage the smallest centers, something that is also accessible on the portal, on the website. Yeah. We have posted applications of a variety and the diverse type of centers that have received the designation. So the center that I've described with 500 deliveries, we have larger centers, but that are community practices.
That's what I was going to
that have received it. And so it's not just Stanford, Brigham, Hopkins, Columbia. It's really, really diverse. It's also international. So I didn't mention it earlier, but we have over 100 centers now around the world that have received the designation. And we get the thank yous from those centers, I would say particularly from the smaller centers, the non-academic ones, who say, thanks to this, we have improved our, we were able to leverage and go and request. The leveraging is really, so it was really not about self-congratulating the bigger centers, but allowing the centers who are very close, or even those who were not close at all, but to work over a year or two to achieve what is what is required to provide safe and an excellent birthing experience for mothers.
Two other questions that, if I may, Desiree. Is this all in the public domain? Can we look up the list as a non-member and see the criteria and the
It is.
excellent centers?
Obviously it is. Although to be transparent, we do encourage and strongly encourage strong membership amongst the providers to SOAP, and the person applying for the Center of Excellence designation, so the PI, if you want, the applicant needs to be a SOAP member, because we believe that not being part of this community is an impediment to providing excellence in care. The second new feature, which I'm very happy, and knowing what I care about, you might guess what we've done, is that we have now gone back to all the designees, and the future centers will also be able to sign an agreement to have de-identified data be utilized for QA projects, because there is an amount of information through the Centers of Excellence that we believe can inform future consensus statements. We can identify gaps. We can identify, room for improvement and QI projects. So centers now are asked to agree or not agree to opt out from having de-identified data go into research projects and publications. And also, because we have such a number of researchers within our society, there's some projects where we've been asked, can you tell us who does this, or can you tell us who does that, so we can approach them? And we said we need to get consent from the PIs to agree to have sort of this matchmaking between the SOAP Centers of Excellence applications and researchers interested in digging into research questions. I'll give you an example. General anesthesia. We record the general anesthesia rate, and it is a criteria, an essential criteria. So we've been asked to share information about the general anesthesia rate, which we haven't, but we're now having the centers say whether they agree to have data from their applications shared for specific projects. This goes through the SOAP Research Committee, and we're doing it, I think, with a really thorough due diligence process to allow researchers to access centers with specific questions.
So my second question, which I think is the trickier one, is revalidation, and does anyone ever get their plaque taken away, which is leverage to say, hang on, purse string holders, they're just about to take my plaque away because you unplugged my difficult airway cart.
Thank you for asking. So we have a renewal process, and the cycle is 4 years. So since the first designation was in 2008, the first batch renewed 2 years ago. The second batch is renewing this year. We will be announcing the SOAP Centers of Excellence new designation renewals this afternoon.
Okay.
And next year we will be, renewing those who applied 4 years ago.
So I'm taking this as an extension of the second question. So we're not naming names, but has anyone had their plaque taken away yet?
Yes.
Oh, that's very well done. Not, that's not, we're not celebrating
good for that,
the fact, but it's very meaningful, to take away a designation.
So I would be less strict, severe, or harsh than taking the plaque away.
You know what I'm talking.
But no, I know what you. But this is an important process, and we struggle to say, "Oh wow, they got it 4 years ago, and we're not renewing." But we went back, so talking about due diligence process, and we said they were on the cusp for one of the essential criteria, and actually the number for that essential criteria got worse. So we said, these are the things we recommend. Let us know how we can help you. This is what we recommend you do. Come back next year.
So a year on the naughty step.
A year on the naughty step. And again, it was a very difficult process to go through and say no. But we thought if we want to feel that we're doing it in a rigorous manner, which we want to, and we want to be credible, we have to stand behind what we say we do. So yes, it's come back next year with better numbers.
And Desiree, you're a VP of quality. I've sort of worked in that space in the past, and we really appreciate being on the receiving end of it, because if there's no naughty step, you can't go back to the purse strings and say we think we're a centre of excellence. We're this ivory tower. We're now on the naughty step. So if we don't get off the naughty step next year, we won't be a centre of excellence. Sorry to.
No, I think I think it's very important as someone who I'm always working with hospital partners to say, what can we do to elevate what we're all collectively doing for our patients, and, centers of excellence, and going for those designations is really important, and we want it to be very meaningful.
And so some of the process, again, the review process generates bullet points, and we thought that if we renewed the designation, we weren't helping that center. We would just be saying, you're sort of not doing great, not your fault, but we're not helping you get great. So we specifically said what we think should happen and we believe can happen. But this will allow the center to go back to some of the stakeholders and say, this is what we need. We're not compliant right now, and this is what we need. So we're really not doing it as a way to, but to give, to leverage, to allow them to leverage. So I think we've gotten to a point where I think we're really doing a good job in helping the centers, and I think they feel it. Yeah. And we really hope to encourage centers that might not feel they're meeting criteria now, not to feel shy. We're going to give you the tools. We're going to provide, first of all, a consultancy, guidance. The people on the subcommittee that want to help. What we're not doing, maybe one day we'll have the funding to do that, is that we don't visit the centers, which I think might be a next step. And we also don't, it's on an honors system, right? We don't check what people do, but we don't go and see, do you really have the difficult airway cart you said you have in the labor room? But we do request protocols. And some people give us generic protocols, like, up-to-date protocols. We say, no. We need your hospital, your specific institutional protocol for this theme. We don't want you to send us, we do the SOAP consensus statements and copy the steps from the SOAP consensus statement. We want to see how it is implemented. And some people in their application take it really seriously, and we have snapshots and screenshots and documents and uploads. People can upload as much as they want. Centers who don't upload anything, usually we'll tell them, please upload things. So there's a back and forth, and there's a rebuttal, and we review again. And at the end of it, we decide whether it seems legit or not.
Yeah.
So, and it's interesting. I enjoy the process on the reviewing side to see where there are gaps. And again, this is how it feeds our desire to, inform, lectures, new consensus statement, visual aids. The education committee can produce more content. We've just thought of another thing we want to do, like QA review for when patients got a general anesthetic. So everything is feeding everything. The clinical practice feeds the research. The research allows to provide the consensus statements and the guidelines. And so really talks to each other within. It's one committee and the other, and we definitely don't work in silos.
Well, it's been wonderful to learn more about this organization. Phenomenal work by everyone here, and we've just loved hearing about it. So thank you for everything that you do. Thank you for sharing all of this with us and our listeners. It's really important. We're going to signpost everyone to the site so they can look up all the information that we talked a lot today. So yeah, be sure and check that out. Ruthi, you're fantastic. Thank you.
Thank you
for taking the time out. And thank you for listening to TopMedTalk. As you know, you can always find us at TopMedTalk.com. On social media, we are there. YouTube, it's a new channel for us. If you see us on YouTube, give us a thumbs up. Subscribe to our YouTube channel so you have all of our great content. Thank you again to SOAP for giving us this booth space here in the exhibit hall, and to all of our sponsors that keep the lights on and keep TopMedTalk free and open access to the world. Cheers, everybody.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.